winter storm warning tonight. We're expecting snow, which is so exciting. So nice to see everybody. Again, CN Colorado Springs is the home to Fertility with Fink and Friends. And I'm also the medical director at the Miami Center of Excellence for Gynecology and CNY Fertility's monitoring station right there in South Florida. So happy to have everybody with us here on Tuesday at just about 6 o'clock Eastern Time, 4 o'clock here in the mountains, 3 o'clock in the Pacific. And again, gosh, a beautiful day. If you're familiar at all with Colorado Springs, you'll know the weather here can get very kind of kooky. It was 50 degrees outside at lunchtime, and by tomorrow morning, I think we're supposed to have about 10 inches of snow. So if you are on the way to Colorado for a procedure, please do check in with the airline, or if you're heading in by car, please drive carefully. And to all our friends in the rest of the CNY Nation, and of course around the world via internet, I'm glad to have you here with Fertility with Fink and Friends. I will have a very special guest joining me here in just a moment, but first like to say hello to some of our friends who are joining us. Lady Cadmium, nice to see you there on the CNY side. Hi to Mayeli. Oh, Mayeli, hey, how are you? Good to see you. So we've got a bunch of different feeds going here, and so if you see some schizophrenic eyes looking all over the place, we've got Facebook and YouTube and LinkedIn right here. We've got 3 separate Instagram feeds. So we're kind of all over the place here. We're going to do everything we can to answer your fertility questions today and to talk about some things of mutual concern. My number one concern today is how come the smoke detector always starts beeping when the batteries are low in the middle of the night? I think that's a fair question because, of course, mine did it all night long. And when it starts at about 1 o'clock in the morning, there's nothing that you're going to do to affect that battery. Am I going to go get out the ladder and try to change that at 1 o'clock in the morning? The answer to that is clearly no. But why does it always happen at night? If you have such an answer, please let me know. Hi, Geldy, you're going to be starting your treatment with us, and we're so excited to have you. You know, getting you guys a family is what keeps us coming into work every single day. And one of the things that I wanted to address, and we've talked about this a couple of times before, is exactly what is reciprocal IVF. What is reciprocal IVF? Reciprocal IVF is for a same-sex female couple where one partner provides the egg, we make the embryos, and then the other partner carries the embryo or carries the pregnancy. That's called reciprocal IVF. And that's something that we're very proud to be able to help everyone who is interested. Betsy wants to know, what is low-dose naltrexone for? It is confusing because sometimes you get that big package of medications and you have no idea what some of these things are. Typically, CNY sends out to you both your both your stem meds and your retrieval meds as well. So you may be getting some stuff that's specifically for retrieval. So just kind of be aware of that. Low-dose naltrexone is considered to be an immune modulator. It increases your endorphins. Endorphins, that's what happens when we get the runner's high. That's what happens in certain other circumstances in our life. And it is said to help with the immune system. In the anti-aging community, low-dose naltrexone is used over the long term. And folks who use long-term low-dose naltrexone will tell you that they never get sick, that you don't get the cold, that you don't get, you don't see the flu. But specifically as it pertains to fertility, it's because it increases endorphins and is said to improve both receptivity, implantation of embryos, and in the first part, with egg quality. Good question there. Hey, before we take any more questions, I would love to introduce my very special guest today on Fertility with Fink and Friends, because it's good to have friends, and you guys are all my friends. Thank you for being my friend, and thanks for watching. But my gosh, it's nice to have friends at work too. So without further ado, would you please allow me to welcome our extraordinary nurse practitioner, Brandis Montez. Brandis, welcome. Come on in. Brandis, if you haven't met her, works here with me at CNY in Colorado Springs. Brandis will help with your consults. She helps in the clinic. She does both retrievals and transfers here. I'm very proud to say that Brandis is one of the only female providers here at CNY Fertility who can do your transfer and your retrieval. In New York, some of the nurse practitioners sometimes will, but Brandis is a routine face right here at CNY Colorado. So Brandis, welcome.
Thanks.
If you followed, by the way, let me just say, if you haven't followed my Instagram, please do that. It's Randy Fink MD. Oh, hi, Christina. You think I didn't notice that you joined? Wait, let me hit the button. Wave. Okay, I waved at you. If you have seen the Instagram lately, by the way, hi also to some of my other friends. Hi, of course, to Amber. Hi to Sarah, who I just talked to on the phone. Hi to hi to everybody who's been with us this week. But if you haven't followed Brandis's Instagram, which is Brandis Courtney, Brandis is embarking on an egg freezing cycle, and so I thought we would talk. Hi, Alexis. I thought we would talk a little bit about egg freezing. Brandis has done some really fantastic. She is actually a social media wonder. She does some great production. All of the CNY videos that you see that come out of Colorado are done by Brandis. So, Brandis, what made you decide that now is the time for egg freezing? Well, first of all, for those who may not know, what exactly is egg freezing?
Yeah, so egg freezing is where we can basically take eggs. We grow eggs in both ovaries. We take them out and we freeze them. And so a lot of times, especially I know a lot of women my age are like, okay, I know I want kids. I don't know when I'm going to have them, but I know I don't want to have to worry about my biological clock. So this is a way of taking the eggs out, freezing them, and then you'll always have, or I'll always have 27-year-old eggs. So if I decide that I don't want to have kids until later and I have trouble, or I'm having a second and I'm having trouble, you can always go back and have younger eggs. So that's kind of the purpose of egg freezing, for more of a social construct reason.
So really, it's like it's an insurance policy.
Yeah, so you hope you never have to use them, but if you do, they're there.
So you can still get pregnant in the normal way, but the eggs stay here and wait for you. How long do frozen eggs really stay good?
As of right now, forever. So
forever.
There is really no limit. I think there was some news story about somebody that just had a baby from eggs that were frozen for 14 years. So
wow,
that's pretty cool.
Well, so we were getting ready to start the egg freezing cycle. In fact, so if you've seen, again, Brandis's Instagram, Brandis Courtney, BrandisCourtney. Brandis Courtney, you just did a great series of posts, of reels about using Omnitrope. So what is Omnitrope, and why did you decide to use it?
Yeah, so Omnitrope is human growth hormone. And so it helps to increase insulin growth factor 1, or IGF-1, which helps other factors, helps your eggs to grow more receptors that are more responsive to follicle stimulating hormone. And that's the medicine that we give you synthetically to grow those eggs. Really here, we've just seen a lot better outcomes with Omnitrope. People respond better. Typically, we get better quality eggs and embryos. And considering that I do kind of only want to do this once, I figured I would give it a shot.
So Omnitrope is typically something that we use for priming. And priming is when we give you medication before we start the stimulation process in order to try to improve something about the process, usually egg quality. Omnitrope human growth hormone may have the ability to help to stabilize some DNA, which starts to become altered as we mature. But that's a priming thing. And we were going to be starting actually a retrieval, but you got a little sidetracked.
Yeah, I got COVID.
COVID.
So tested constantly, was negative, and then one afternoon I tested again and was positive. So, there's a lot of different views out there. To be honest, there's not a lot of great data. So some people, some studies show, which there's not very many studies, but some things show, as soon as you feel better, you can go into a cycle with no really big difference in egg quality. Some say that if you don't wait, you can't have top embryo quality. There was like 9 people in that study. So, really, and then you read about folliculogenesis takes 3 months. So do you want eggs that were exposed to COVID? So then that was another thought. Some people say wait a cycle or 2. So, the patient side of me and the provider side of me reading studies that there's really not a lot of great ones, looking at that and trying to interpret it and decide what's best for you can sometimes be overwhelming. But I knew that if I jumped into a cycle and didn't really have a great outcome, then I would regret it. So I decided to wait.
So the data's not great, but there's some suggestion that COVID may have some effect on embryos. What would you tell one of our patients who said, well, I'm just getting over COVID, but today's cycle day 1, I'm thinking I want to start my stim. Should I wait?
I think a lot of these are very personal questions. For me, I get anxious about everything, and he knows because I work with him. So, in the back of my head, if I'm questioning something, I think usually in my gut, I feel like the right choice would be to wait, even though I did kind of want to get it over with and just do it. In the back of my head, that would always be there about, okay, well, are these eggs just going to fall apart one day because they were exposed to COVID? So I think if you're questioning something, especially something like this, I would just say, to wait a cycle or 2 before doing it.
Better off to wait. If in doubt, I agree. I think waiting kind of makes sense. But so since you're waiting, you decided to use that time wisely and started to use some Omnitrope to see if we can't do something for egg quality in the meanwhile. So that's just kind of using your time wisely.
Yeah, so I actually did an ultrasound cycle day 3 of my cycle now and looked, and I had a bunch of follicles that were not in sync. So some were big, some were medium, some were small. So, that was one thing, and I wanted them to all grow at the same rate. Those of you that have done IVF know that's important. We want to get as many eggs as we can. And honestly, I think going home and eating ramen noodles every night probably isn't the best. So I think, a couple months of actually cooking, which I don't like, but we'll do it for the sake of this. Doing birth control to kind of synchronize those follicles, Omnitrope, some vitamins. I think, I feel a lot better going into a retrieval knowing that I prepped as best I could.
Well, that I think makes really good sense. And Away Page Goes is asking, any thoughts about COVID close to transfer? In your review of that data, did you see anything about transfer, or was it really only about retrieval?
So to be honest with you, I didn't look up transfer. I looked up stimming, so IVF for retrieval. However, to be honest, it's probably the same type of data you're going to find just because COVID's so new. So the studies are very small. I think your name is Paige. So Paige, I think if you were to do a transfer and it failed, in the back of your mind, are you always going to say, oh, is it because I had COVID? So I would say maybe give it a cycle. If you feel better and then a week later you get a cycle, maybe wait till the next one, only for peace of mind.
And I agree with that. I think that once you get a cycle, the system kind of reboots. And COVID is predominantly an inflammatory disease. In the early days when folks got really sick with COVID in the hospitals, and we all remember, what that was like, and it's traumatizing, really, I think, for everybody. And almost all of us can say we lost someone we loved in the early days of COVID. It's because of an issue in the body that's called a cytokine storm. Cytokines are an immune modulating biochemical, and they rev up. You get stormed with this immune modulating chemical. So basically, your body is trying to combat the virus by increasing inflammation. And inflammation, as we know, stands in the way of pregnancy. So I agree, but I think that once you're clear of COVID and you've had a cycle, I think it's fine to probably think about proceeding with a transfer. Now, we had a question over here from the CNY side, and it looks like this came from New York, NY Cali, it looks like. What causes follicles to grow at different rates? And really, what did that look like in your ultrasound?
So basically a baseline ultrasound is average done on day 3. And so typically at that point, you want all of your follicles to be, we call it quiet ovaries. So we want all of those follicles to be small, so that way when you start growing, they grow at the same rate. When you have follicles of all different sizes, that can be caused from a variety of reasons. Whether you have irregular cycles, meaning your follicles in your brain or your ovaries in your brain really aren't communicating that well. Sometimes that can happen with PCOS or thyroid disorders, high prolactin. That's why we check all of these things. Sometimes that signal can kind of get messed up. Yeah. For lack of a better term.
So you decided to start some birth control. How are you feeling on the birth control?
I was a little nervous, just because I've never been on birth control before, really, any type of birth control. So to start something like that, was a little nerve-wracking. And I always joked with him about, okay, do I feel different? Is my hair falling out yet? Do I have acne yet? Because you hear all of these horror stories, and then of course, you're bored at home, you get on TikTok and you can type in, don't do this.
Don't do this.
Birth control side effects, and then just don't do it. So I feel fine. I really don't feel any different. I've only been on them for about a week. So far, so good.
So birth control seems to, birth control suppresses your FSH hormone. FSH, follicle stimulating hormone, is the hormone that stimulates your follicles in the ovaries. So when we suppress the FSH, you're not making eggs, or you're not producing eggs that will go on to be ovulated, and may allow the eggs to kind of all just take a little rest, to kind of just chill out, so that then once you're done with the birth control, that you're able to kind of start from scratch with everything at about the same size. So that's what we call synchrony of the follicles. Dyssynchrony happens when the follicular sizes are dysynchronous, meaning to say, maybe getting close to the time of trigger, you've got an 18 millimeter, a 17, a 16, a 12, a 10, a 9, a 4, a 2. So they're just kind of all over the place, instead of being really synchronous, or kind of all in line together. Arath 10 says, well, will birth control suppress the total number of follicles you can retrieve?
No. So the same number should come out. If you've been on it for a long time, I may say come off for a little while, but for a short priming time, it shouldn't, especially if you give yourself a gap. Meaning you give yourself that period, the withdrawal period, then it shouldn't. I actually have used birth control for patients that haven't responded that well to our medications. Like Dr. Fink said, it can it tricks the brain into thinking there's an ovary or an egg already growing. So it stops sending down that FSH. So what happens to the receptors on those follicles for FSH is they open up really wide. So that way, when we do give you that FSH, sometimes patients will respond better to the FSH. So I always like to say, maybe if we make those follicles a little thirstier with some birth control, you'll respond better to that FSH. So it's another reason we use it.
And there is some controversy over that, but I think of it as kind of holding the fillies behind the gate. And then suddenly you stop the birth control, the gate goes up, and those eggs say, we're ready to go. Let's do it here. And we do see that happening sometimes. Here's a question from Waleska. What's a good number of follicles on a baseline day? And so what you're asking about there, Waleska, is what's called thank you. And what you're asking about is, I don't remember what it's called, is an antral follicle count, or an AFC. We don't typically at CNY use the antral follicle count because really it hasn't been shown to be reliably predictive of what's going to happen to you in your cycle. What is maybe a little more predictive of how you will respond to IVF is the hormone level that's called the AMH, the anti-Mullerian hormone. And that's why it's a test that we recommend for everyone, because it gives us an idea what your response may be. A lower AMH means a lower ovarian reserve, and a higher AMH means a higher ovarian reserve. And when we see that number over about a 5, it's suggestive of polycystic ovarian syndrome. Now, what does that mean? Does that mean that IVF is going to work for you or is not going to work for you? No, absolutely not. It's just suggestive of how we're going to prescribe the medication. So on that subject, it looks like Danae. Hi, Danae. Nice to see you. If you have a lower AMH and can't go on birth control, what do you recommend for priming for synchronizing follicles? And that's a tough one. And when you say can't go on birth control, I'm going to take it that you mean that you have some medical contraindication or reason that you can't be on birth control. Is there anything else we can do to try to synchronize follicles? Not so
really
much. Yeah.
Usually the combination of estrogen and progesterone is typically what we use. But I know I was a little afraid about the estrogen part of birth control. So I am using a low estrogen birth control. So there's different options for different patients and reasons. So make sure to ask.
Yes, indeed. And looking over on the Facebook side, and forgive me for trying to move my head over and getting it in your way there. Sorry about that. Sally is asking about Omnitrope. Since we were talking about it, it wasn't on your med list. Can you ask for Omnitrope? And the answer to that is yes. If you feel like that is a good choice for you and your prescriber didn't offer it outright, it's not because it's not a good choice. It may just simply be that they didn't think about it for one reason or another, or didn't think that it would be, really the most important choice for you. But adding it has really little risk. Would you agree?
Yeah.
So when you're giving yourself, and again, please take a look at and friend Brandis's Instagram profile. She has some great videos about mixing the Omnitrope and injecting it. So you're doing that sub-Q injection with the Omnitrope. Was that, and I think you mentioned that was the first time that you've given yourself a sub-Q injection. Was it as bad as you thought?
No, my cousin actually froze her eggs, so I gave them to her a lot, and the needle was really small. So I think the other part is that I was filming it for you guys so that you can see what it's like. Maybe if I wasn't filming, I would have hesitated, but since it was on camera,
you just did it.
I didn't. But you really can't feel it. The needle's thinner than a strand of hair, so.
Since we're talking about that sub-Q injection, I do want to maybe you want to talk a little bit about that wonderful follistim pen. Brandon's going to grab something here. So when I do a sub-Q injection, and we do sub-Q when I give one to someone else, or have done it myself for a number of different reasons. Brandis mentioned as well, and it's the same thing for if you're doing your stimulation with the sub-Q med. I pinch the living crap out of this little layer of fat here where that injection has to go. Why is it useful to pinch it so hard?
Because then you're focused on the feeling of the pinch and not the actual needle.
So there's actually science behind that. It's called the gate control theory of pain, that you're pinching. So you're occupying the nerves, which would otherwise feel that needle going in. And when they're occupied with something else, they're not going to feel the pain. It's the same reason why, let's say you bang your knee on the table and you go, and you start rubbing it. Rubbing it is doing the same thing. You're occupying the nerves. You are overcoming the nerve stimulus from banging it on the table with rubbing it with your hand. So I pinch really hard. I place the needle up against the skin, and I like to rotate that area. And I would show you on me, but I'm sure Instagram will pull the plug on that because that's something nobody needs to see. You pinch really hard and you rotate back and forth as I place the needle up to it, and then I gently advance the needle. And when you do that, really literally, you don't feel it at all. Brandis has the follistim pen here. So why don't you show us how that works? Many of you may already know this. It may be already information, but here it is coming directly from the nurse practitioner.
Yeah, so these are the follistim pens. So they come apart. Let's see, maybe. They come apart like this. You will get a little cartridge, and I don't have the demo kit with me, but the cartridge goes in here as I drop it. And then you screw this back on, and then the top of this comes off, and you attach your needle. So the needle comes in a little cap. You attach it and twist it on, and I'll show you guys the needle. You really, I don't know, I go to all the cameras, but
very fine needle.
It's a really
right?
fine needle, so really you can't feel it. Although I hear men up here burns, so we'll see. But then you draw this up to however many units you use. So if you're at 200, then you push it down, and it'll actually push down if you have a cartridge in here. And then that's it. So it's kind of like an insulin pen. So.
And in the same manner, you pinch the skin and just inject.
I couldn't do it in my arm, but you pinch, you give it to yourself, and then push this down, and then that's it.
Gosh, I just need to comment here. Danae, who we just talked to, had a transfer last October, and it worked, but she's saying worked a little too well. The embryo split, and you lost conjoined twins at 16 weeks. So, gosh, our heart goes out to you, Danae. And just like we talked about last week, for those of you who are here, you know, having a pregnancy loss after IVF is like insult to injury. Having to go through the process, getting that positive pregnancy test, watching that pregnancy start to grow, and then seeing it get lost for some reason is just really heartbreaking. So Danae, you know, hopefully what that means to me is that now at least we know there's something about the system that works for you, that you were able to implant a pregnancy, that pregnancy was able to grow. So a valuable lesson. It's something that shows us that yes, the system is working. So now we just got to get the right embryo for you there. Again, our hearts go out to you. Looks like Leslie is asking, do we do second opinions? Yes, of course. Leslie had one egg retrieval at 38 years old. looks like the egg made an embryo, but the embryo did not make it past day 3. So this is a very common question that we have at CNY, and that's, do I do a day 3 transfer, or do I wait and let the embryo grow to the blastocyst stage? There are many practices that will require you to grow to day 5 or to blast. And the reason for that is because they are looking for an outcome. That, yes, it's true. We know that when an embryo has made it to blast, it is more likely to give you a baby. But that doesn't mean that a day 3 embryo is not going to give you a baby. If it's going to grow, it's going to grow. And in fact, it may grow inside of you when it didn't grow in the lab. I always say you may have the magic sauce that we don't have in the laboratory. And so all day long, Brandis and I would rather see an embryo that's able to go inside of you than an embryo that doesn't grow in the lab. So when folks are asking about day 3 versus day 5, what's your advice?
We do, and we talk about this a lot, we do have something called CNY protocol. So if you have 5 or more, we recommend growing them to blast. If you have 4 or less, we recommend day 3s. So, if somebody were to ask me that with multiple embryos, let's say they have 9 embryos, I would probably say, well, let's grow to blast and see what we get. If you have fewer, I agree, we would rather see you get to a transfer, because no matter how good a lab is, it's not going to be a uterus, and maybe you have something that's going to be better than a lab. So a lot of the times we would rather see you get to a transfer than go through a cycle and lose them all. That's devastating.
So don't be afraid of a day 3 embryo. Yes, a blast is a good thing. It's a fully functioning little machine, whereas a day 3 embryo is still trying to divide in order to see how it's going to do. But as Brandis said, at the end of the day, it's way better in you than it is not growing in the laboratory. So, hey, Llama, it's nice to see you over here. How long are we booking out for consults? I don't know the answer to that question, but you do raise an interesting point about donor embryos. So what would a donor embryo be?
Well, yeah, so a donor embryo is actually an embryo that's already made from somebody else's egg and somebody else's sperm. So again, an embryo that's already made, and then you carry that embryo, and that embryo is yours. So a lot of people that are done with IVF and they have embryos left over, they will donate their embryos to either couples that can't make embryos for some reason, and so I don't know how the whole process is to get them. That would be through our donor team, but basically you get that embryo, you do a transfer with it, and then that's your baby. And to me, that's so cool because you still get to carry, and like Dr. Fink talks about epigenetics a lot. It's cool to play that type of role with a donor embryo to still carry.
Now, here's another thought for those who are thinking about donor embryos. The last I checked, the wait list for donor embryo was quite lengthy. Another option besides using an embryo that was created by someone else is to simply, on your own, purchase a donor egg, use either partner sperm or donor sperm, and to create your own embryo. So essentially it's a donor embryo, but you're creating it from scratch so that you can carry it on the inside. And the rate limiting step there with making your own embryo using a donor egg is just simply selecting the donor. So that can be done within a couple of months, whereas the wait list for donor embryo may be quite a long time. So I think the cost ends up being really very, very similar. So if you're thinking about donor embryo and you're frustrated by the wait, there is a really pretty quick alternative to that. Hey, with ovarian PRP, does the procedure, well, first of all, tell us a little bit about ovarian PRP, Brandis, and should it be done before IVF? Can it be done with IVF? And how does it really help? Under what circumstance do we use it? And as Amber asks, when do we use it? Does it have to be done at a particular time during the cycle?
Yeah, so ovarian PRP is where we draw blood, typically from your arm, and we spin it down to get the plasma part, and then we inject it into your ovaries. So it's the same process as an egg retrieval. It's done with transvaginal ultrasound. We get a needle, we stick it into each ovary. Half goes into one ovary, half goes into the other. The thought is that it will increase egg quality.
Yep, and so you can actually do for folks with who have issues with egg quality or ovarian reserve, we can and who do a cycle of IVF, we can actually do ovarian PRP into the ovary at the time of your egg retrieval if you're planning to do another retrieval. So let's say you're going to do a back-to-back cycle, and that back-to-back cycle means that, okay, so the back-to-back means that you wait, you get your period, and then you start on your next stim again. So the reason that's a good thing is because the medication that we use, let's say the medicine that we use in January, is going to continue to help you to recruit eggs in February. So typically we see some improvement in those stacked cycles, especially if you think about adding ovarian PRP. Now, there's not a lot of evidence on it. Is that right?
No, yeah, there's not. I mean, again, IVF and the whole field is so new, and ovarian PRP is even newer. So really, there's not a ton of good data on it yet, but it's one of those things where, you know, if patients are asking about it, it really can't hurt. So if you're considering it, really there would be no reason not to, unless you know, you're going to do one round of IVF. It wouldn't really be worth it to do PRP and then not do IVF again. So if you're going to do, you know, either do it before you're going to do IVF, or if you're going to do back-to-back cycles.
So empirically, I will tell you, I think it's a great thing. I have really seen good results with it. So certainly if that's something you're interested in, please talk to us about it. We would love to help you with ovarian PRP. Well, Leska asks a question there that, since we were talking about Follistim, Leska used 200 IUs, and there's 100 left. Can it be used later? And what is this about the excess of stimulation meds left in the cartridge?
So this is cool. You know, it's funny because I always hear the nurses down here talk about excess in the cartridge. And then when I actually got the meds in my house, when my cousin did it and I was giving her shots, we gave her the shot, and then we're like, okay, you know, we did this much. This is how much the cartridge is in. And we pulled it out and we were like, oh my gosh, there's still med left in here. We did something wrong. So now I know what the nurses are talking about. So the cartridges will come with overfill. So let's say you got 300 IU cartridges, or you just got, a cartridge that's 200 IUs. I don't know if they make them like that, but let's say you did. So you can draw it up to 200. You give it, you have leftover, save those leftovers. And then you can go back later. So the next day, you put that cartridge in here, you draw it back up to 200, you give yourself the shot, you push that this thing down, and it'll go down to however many you have left. So it'll go down to like 100, and you'll say, okay, I have 100 left. So then you get another cartridge, put it in, and then you just give it to yourself again and keep doing that till it's down to 0. So this will stop itself when that cartridge is empty, and you just keep replacing the cartridges. The cool part is that you don't have to buy more meds. The down part is that you have to do multiple pokes, but
it's worth it to save the money, because as we know, these are not inexpensive medications. So what a very cool thing. And thanks for that question. That's a really good one. I wanted to, I think if I'm pronouncing it right, is it Ciara? Ciara asked a question. I think that's a really cool name. So just, So you know there. It looks like Amber already answered it. Amber is our agent, in fact. Thank you, Amber. Can I use a combination of what eggs my body makes and donor eggs? And the answer to that is yes. As Amber said, that's called a donor egg add-on or a donor egg backup. And basically what that means is that you go through the process, you do IVF yourself, and we retrieve whatever eggs we're able to retrieve. But then when they fertilize those eggs in the lab with the sperm, then we also fertilize the donor eggs that you purchase, so that one way or another, we're going to end up with good eggs that have a potential to get you pregnant. So donor egg backup, donor egg add-on, please do ask your providers about that, because a very useful thing. And it's especially useful when maybe you're a little bit more mature and we know that your odds of success with IVF start to decrease. Well, if we really want to maximize the chance that we're going to be able to get you pregnant, but you also want to maximize the probability of trying to use your own egg, that's a really brilliant time to use a donor egg backup there. So good question. Ashley's asking about PGT testing and our opinions. Ashley has PCOS. She has a high AMH and she's on the fence. So Brandis, how do you counsel people about PGT, and what is PGT, and when's the right time to do it?
Yeah, so PGT-A testing stands for pre-genetic testing for aneuploidy, or pre-implantation genetic testing for aneuploidy. So aneuploidy just means abnormal number of chromosomes. So not only does it tell you if the embryo has the right number of chromosomes, or euploid, meaning normal number of chromosomes, it also can tell you if those embryos are male or female. If you don't want to know that, they can just block it out. But that's what PGT testing is. A euploid embryo, or a chromosomally normal embryo, gives you about a 60 to 70% chance of pregnancy, whereas an untested blast, because we don't know if it's chromosomally normal, will only give you about a 30-35% chance of pregnancy. So a lot of times people will use that test to more so narrow down a larger group of embryos if you have a lot. So I forget her name, Ashley, with PCOS and a high AMH, you may have a large number of embryos. And so PGT testing may help you to narrow down which embryo to transfer. And the other reason I use PGT testing is if you come here and you see my goal is 3 kids, typically, I like to use PGT testing for family planning. So I like to tell people, let's try and get 2 embryos per child that we want. That way we can have those banked before we start doing transfers. So that way you don't have to think about doing another retrieval later on when we're older.
Yeah. So I think of it like this. If we have, let's say that you're able to make 20 embryos, that's a lot of embryos, and that's potentially a lot of transfers that you have to do before you get to the ones that may be normal, because those quote unquote normal embryos are the ones that have the highest probability of being able to get you pregnant. Well, we use both nature and science to help select out the better, the normal embryos. Nature, because the embryo has to grow to the blastocyst stage. So like we talked about just a minute ago, all the embryos are not going to make it to blast. So the first test is which ones are nature going to let grow to the blast stage. And then we use science. Then the embryo is biopsied. And then the biopsy tells us which of those have believed to have normal chromosomes. So that idea of an embryo biopsy is something that frightens people. They're actually taking a piece of the baby.
Yeah, so somebody actually had asked, can you take an arm off if you guys aren't careful? No. So there's typically, I describe it as there's 2 parts to an embryo. That I'm not an embryologist, so I'm saying this wrong, but this is how I understand it. So the outer part of cells is called the trophectoderm, which is a fancy term for this is the part that's going to become the placenta. And then the inner part of that embryo is called the inner cell mass, or sometimes you'll see it as ICM. That's the part that becomes the baby. So when we're doing biopsies, they only take about 5 to 7 cells from what would become the placenta. So we never touch the inner cell mass. So some people will say, well, what if you do? We don't have studies on that because we don't do that. So no, that's taken from the outer part.
Yep, it's called a trophectoderm biopsy. It's biopsying the portion of the embryo that becomes the placenta. Over here, I'm not sure how to pronounce the name, but it's a great question about a hydrosalpinx. A hydrosalpinx is fluid that's in the fallopian tube. Does the hydrosalpinx fluid stay in the tube, or does it continually spill out? And if they do spill out that fluid, where does it go? What is the percentage of successful frozen embryo transfer with a hydrosalpinx? So a hydrosalpinx is fluid that collects inside the fallopian tube, and it's typically doing that because that tube is damaged. It's usually because there's some form of a seal. It's sealed off at the far end, so fluid collects in it, and it has some form of a seal at the close end to the uterus. So if we want to use a little example here of my friendly neighborhood, uterus, yes, I do keep it in my office. Okay. Yeah. Okay. Just go ahead and say it. So here's uterus and here's fallopian tube. If this side of the tube is blocked and there's some form of a blockage on the near side here as well, then fluid will collect in that tube. And when it does that, that fluid is toxic to an embryo. So the question about what is the percentage of success with hydrosalpinx, I'm not sure we can say that, because it would really be unethical for us to recommend that you do any kind of transfer with a hydrosalpinx present, because that fluid, we said there's a blockage over here on this side, and that's why it's not going that way. When it's blocked here and there's some little blockage here, there's a risk that just may be a microscopic blockage where fluid can go back into the uterus, and that fluid is really poison. So the recommendation is that we treat that hydrosalpinx. How do we treat it? Well, 2 different ways. We can actually remove the fallopian tube, which is probably the more common way, or some people will simply opt for blocking, putting a clamp or a clip on the near portion of the tube in order to block it off, to be sure that fluid doesn't flow that way into the smiling uterus. So that's what a hydrosalpinx is, and that's a great question. I do want to answer. We've got about maybe 10 minutes or so left here, and if you're just joining us, gosh, we're so happy to have you here. Fertility with Fink and Friends from CNY Fertility in Colorado Springs, and with me is Brandis Montez, nurse practitioner, and a great mind in the practice of fertility. Atif is asking about poor sperm quality, or about DNA fragmentation. And we've talked about DNA fragmentation before. So what is a sperm? Sperm is basically a little piece of DNA, a little piece of genetic material with a motor on the backside to take it where it has to go. If something has gone awry with that DNA, then that means that sperm will not be able to function effectively to fertilize an egg. And that's one of the things that we call DNA fragmentation. So there is a test that can be used for DNA fragmentation. And typically, the way we start to recognize this as a problem is if the female gives us a cohort of eggs and we have the sperm, but the sperm cannot fertilize the egg. And so in that scenario, we think there is a sperm problem. It's a male factor problem. The classic solution to treat DNA fragmentation is to use to repeatedly ejaculate, because repeated ejaculation the earlier ejaculations seem to provide the sperm that are first have a DNA with issues, and that the later sperm that come out tend to be less fragmented. So to the extent that it's physically possible for the male, we typically recommend that you ejaculate more frequently leading up to the collection that's being used at the time of IVF. And that's a great segue into Zymot, or Zymote, as some people call it. Looks like B. Mushinsky is asking about Zymot, and it's also a very common question we hear. Zymot is an add-on that we can offer with IVF. And what is Zymot, and how do you describe it to people?
Yeah, so Zymot is a sperm processing device. So it looks like a little cartridge with a circle on it, and then it has a little entry point at one end. So they inject the sperm through this entry point. And again, andrology is probably watching and shaking their heads, but this is how I understand. And then they put it in an incubator. They incubate it for a few hours. And there's a little membrane in there, and then the sperm that make it to the top of this membrane after it's been incubated are the sperm that they use for ICSI, or for fertilization of those eggs. And they're thought to be the sperm that are the best sperm without any DNA fragmentation that kind of won the race through this membrane. So that's what Zymot is.
So it's using a technology to try to help select the better sperm. Do you think that's any different, or would andrology tell you that's really any different than what they do when they sit down and look at the sperm themselves?
No, again, I'm not andrology, but either way, whatever, if you choose to use Zymot or not, they still sit down and look at a group of sperm and pick the best one out of those groups to fertilize an egg. So they want to make sure there's no deformities, it's not swimming in circles, it's swimming in the straight line, all that stuff.
So Zymot is still considered experimental, is that correct? So with I will tell you that if you read the data on Zymot or Zymote, pretty much it comes from the company itself. And whenever you see research that comes from people who are paid by the company, or that is conducted by the company, it's not necessarily something that's a bad thing, but it does call it into question. It does make you wonder. And most of the information that I've seen on Zymot really comes from the company itself. The andrologist I've spoken to will tell us that it doesn't do much more than what they can see. I have been told now this may sound counterintuitive, it decreases the pregnancy rate. It decreases the pregnancy rate because it decreases the miscarriage rate. So it is probably doing something to help select better sperm, but the pregnancy rate is going to be lower because some of those sperm that will fertilize some of those eggs are ultimately going to result in a miscarriage. So Zymot is not something that I typically recommend as routine, but the cost of Zymot at CNY, I believe, is $200. It's $200. It's not $2,000. And so therefore, if that's something that you're interested in, it is certainly something that we can do. I want to answer a quick question over here that came from Alyssa, and that is, does the PGT testing detect specific carrier genes, or just is it normal or abnormal?
Yeah, so PGT-A testing for aneuploidy does just tell you if it's chromosomally normal or abnormal. The test that you would be asking about for carrier genes is called PGT-M. So with that one, if you do PGT-M, you have to do PGT-A and PGT-M. So PGT-M can help to select a specific carrier gene. So you and your husband or your partner would both have to have testing, so that way we know, or they know kind of where to look for this gene. They make a specific probe for it, and then that's PGT-M.
Yep. So that testing is part of what we consider pre-pregnancy counseling. If we determine that you're a carrier of one of these 500 or so different diseases, and it's not uncommon because there's 500 of them. So if we determine that you're a carrier, then we want to test partner. If partner happens to be a carrier of the same thing, it's a 1 in 4 chance then that you have of having an affected baby. And we can prevent that by doing PGT-M. PGT-A, as Brenda said, is testing for aneuploidy and for gender. Gosh, I just want to throw a shout out to Optimistically Infertile, who is now 35 weeks pregnant with a day 3 embryo. So congratulations, your big day is coming up and we're very proud of you. Day 3 embryos can get you pregnant just like a blastocyst does. So as we said before, don't be afraid of that. Alyssa asked, well, since we're talking about this PGT, what if you're using donor sperm? That's a very good reason to do your own genetic testing, because most of the donor agencies or the sperm banks will test their sperm donors and they will report to you whether they are a carrier of something. Now, if you've tested yourself and you are not a carrier of anything, then it doesn't matter what the sperm donor is a carrier of, because worst case scenario, you would produce another carrier, which is not someone who has the disease. Well, and oh gosh, as we start to wrap it up here, I do want to throw in here, Sally's asking about when is Sarasota going to be up in operation? And I just saw a post from CNY, and what did it say?
Summer 2023.
So this summer, Sarasota is going to be up and in operation doing full service IVF with both retrievals and transfers. There is a very kind, nice doctor in Sarasota named Dr. James Condrup, who is our colleague and is a really very, very nice man. Dr. Condrup will be doing the procedures in Sarasota. I spoke with Dr. Kilt, who also told me that he is planning to open a CNY facility in Orlando as well. And of course, we have the CNY monitoring facility in Miami. So I apologize that we weren't able to get to everybody's questions today, but great questions. A lot of folks joined us here. It's been really nice to be with you, and certainly hope that you'll join us again next time. Every Tuesday at 4 o'clock Mountain Time, it's Fertility with Fink and Friends. Thanks so much to Brandis Montez for sharing part of your personal story with egg freezing and with your knowledge of everything that we do here. If we can help you to have a family, please pick up the phone and call us. We would love to see you here in Colorado Springs. We've got some wonderful locations in New York, but I have to tell you, there's really nothing like looking out the window and seeing Pikes Peak and really enjoying the clean air here and the no humidity. And we've got a wonderful staff that is really just waiting to help you. So God bless to everybody. Thanks so much for being here. All the best to you, and we'll see you next time. Good night. And bye-bye.